we've kind of already talked about the first two a little bit. I think naturally I just don't want to be on camera, so. So, if you can see this, we're kind of already talking about fibular head. Same thing if you're on the Gertie's tubercle on the lateral side and you continue to move posteriorly or more laterally, again, however you want to think about that. Eventually, you're going to feel that fibular head, and you can do AP or PA moves, meaning wiggling it backward and forward. And like I was mentioning before, I would palpate this side, but I'm going to try and show you for the camera. Like I was saying before, if you are feeling that superior aspect of the fibular head and you evert your patient's calcaneus, you should actually feel that move up into your hand a little bit. You're not going to feel inches of movement, but you'll feel the wiggle. So if I'm on this side, I'm going to palpate the superior, or excuse me, anterior and posterior aspects, palpating that superior most aspect of the head, and you can kind of feel where it drops down into the neck and it gets more narrow. So easy one to palpate, but just to confirm that you're on fibular head versus Gertie's tubercle, if I evert her calcaneus, invert and evert, I'm going to feel it wiggle. Why would that be?
Because it's going to affect the malleolus.
Yeah, because you're going to have your fibula is going to turn to your lateral malleolus. So as you're everting calcaneus and talus, they're going to push that fibula up. Does that make sense?
Oh, yes.
Oh, yeah. Once you found the fibular head, similar to how you're kind of wrapping your fingers in to feel the tibial plateau, if you wrap your fingers around behind the fibular head, almost into the popliteal fossa, but not quite so far over, and you press fairly deep, it's going to be a little bit different on everyone. You should start feeling a spaghetti-like structure. You feel that one?
Yeah.
It's going to be your common peroneal or common fibular nerve, two names, same structure. Okay? So just finding that fibular head, wrapping your fingers behind. Again, make sure you have your nails trimmed so that you're not stabbing your partners or your patients in real life. And you're going to have to sink in kind of slow because this is a tender area. You just want to make sure you're not, there you go. It might be sensitive. It's kind of a lot like the ulnar nerve where we can actually get some zingers, but it'll feel like a wet spaghetti noodle.
Oh.
Get that spaghetti noodle.
Patellar tendon, we've already talked about this one, but coming down from your patella, middle patella, just straight down, you should feel that firm structure that still has a little bit of give, so you know it's not a bone. You can find the medial and lateral borders, and then to confirm that you are on it, you can put your finger on the tendon, have your patient extend their leg, and it'll tighten up because the quadriceps will be pulling. Does that make sense?
Yes.
Patellar tendon, and then you can also find the inferior attachment on tibial tuberosity. Fun fact, the most common area for tendinopathy is on the medial aspect of this ligament, so that's good clinical knowledge. If somebody's coming in with patellar tendinopathy, some transverse friction massage, ice massage, eccentric work, focusing on that medial aspect will be important. Okie dokie. LCL. So lateral collateral ligament is a little bit easier to find and a little bit more, defined than the MCL. So going back to how we found the tibial-femoral joint line, the squishy space, the tibial-femoral joint line, staying in that joint line. Again, we're not picking our fingers up because it's very easy to hop over this ligament, but moving laterally until you find what should be another thick, firm band, ligament. It will feel like a ligament where it has some good give, good squish. But this one's actually really easy to confirm because you have the patient do a figure 4, and you have them do this if they're in supine, and it will actually tighten up really nicely. Tighten up really nicely where you have a firm tendinous conformation.
Oh, yeah.
So that's LCL.
Oh, yeah.
Oh, yeah. And then, I mean, on some of our students last term, there was just like a rope you could find. It was great. You can also do this, if, like I said, if you're testing or palpating in the supine position, you just have them supine, do the figure 4, find that LCL on that lateral side. And then medially, you're gonna find the MCL. This one tends to be a little more broad, not quite as cord thick as the LCL. Flatter. You're gonna find the anterior border, palpate along that firmer resistance tendon until you come and find that posterior border of your MCL. And then I think the video specifically says not to do the valgus stress, but no. But if you keep your finger and then you just do a little tiny pull, you'll feel it pulling underneath your finger. So you definitely don't want to test.
Consider it doing internal rotation.
Yeah, like slight internal rotation, not a full valgus force on the knee, because it is much easier to injure those structures on the medial side. But a little bit of internal rotation, you'll feel a little bit of pull on that MCL.
Generally for LCL, I'll usually just, if that's all I'm palpating, I'll go straight to fib head first and just work my way up, because that's a very smaller, more specific way to find it. Whereas the tibia, you don't really have a very specific spot that you're finding to move up. So I would find the patella, go joint line to get to MCL. Again, that one's harder to hop over that way because it's broader. But finding the fib head is like a very easy reference point to find your LCL. So either way is fine, whatever you prefer to do.
Yep. Confirmation is the same for both too. Or I mean, if you do Dr.
Same,
Parker's method.
but opposite.
No, you still do the figure 4 to confirm, don't you?
Oh, sorry, I thought you were talking about
Sorry, with Dr. Parker's method of finding LCL or mine, the confirmation is still the same.
Yes.
And then let's start with those. Good?